All right. Hello, everyone, and welcome to today's AP Forum webinar. We're excited to chat about a very pertinent topic. We really wanted to circle back to anticoagulation in older adults and kind of think about what have we learned since FRAIL-AF. And so we're going to be taking that spin today. Looking forward to it. Next slide, please. So we'll go through a couple of announcements on the top here, and then we'll focus on the topic at hand. Slide. We want to also let you guys know, we have actually an expanding international membership with the Anticoagulation Forum, which we're super excited about. So we thought we would mention that in the Zoom, if you're on this and you'd prefer to have the captions in your own language, we wanted to show you how you might go about that. So the live captions with real-time translations are available, and you can select your preferred language using the closed caption button at the bottom of your Zoom, and captions can be turned on and off at any time. So we thought we would share that. Next slide. Also, wanted to let you know about our on-demand boot camp. So in case you missed, you or your team missed the 2025 live virtual boot camp in October, we do have that content available. So I would point you to the AC Forum's website for the on-demand boot camp. So 16 dynamic and informative talks, 2 recorded chalk talks, which are always a very, kind of a fan favorite. And then all of that for $299. So would refer you to that great faculty, as you can see on the right there. Next slide. And connect with AC Forum. If you're going to ISTH, the AC Forum is going to be at ISTH, and we're also going to be at THSNA. So we'll be THSNA. There's some information there about the THSNA meeting. The Anticoagulation Forum is one of the group members, as well as ISTH in Paris, France. If you needed a good excuse to go to Paris and the food wasn't it, seeing the anticoagulation there and going to ISTH should be just what you need to push over the decision limit there. Next slide. And the next webinar, Contemporary Approaches to Secondary Stroke Prevention, New Guidelines, Emerging Evidence and Clinical Application, with a host of great folks to hear from. So I would definitely suggest thinking about that one. That'll be in March. So get registered for that event as well. All right. So you guys have heard enough from me. I'm going to hand it over to our speaker today. We didn't have an introduction slide. I apologize for that. There we go. We have our great guest speaker, Anna Parks. She's a geriatric hematology researcher and assistant professor and director of the Thrombosis Division of Hematology and Hematologic Malignancies at the University of Utah. We have a panelist, Sabine von Preyss-Friedman. She is a practicing geriatrician in the PALT Med, or post-acute long-term care setting, and the current president of the PALT Med organization. I'm Arthur Allen, your moderator today, and we have with me Margaret Fang, a cardiovascular outcomes researcher and chief of the Division of Hospital Medicine at the University of California in San Francisco. So looking forward to this chat. And Anna, I will hand it over to you. Thank you.
Great. Well, thank you so much for the invitation. It's really an honor to be here as somebody who's listened to many of these webinars. So today we're going to have a really great discussion, I hope, with lots of time for questions at the end. But first, we'll go through a little bit about FRAIL-AF, which we've kind of referenced as one of the turning points in bringing at least this subject to our attention. Then we'll talk a little bit about updates in both atrial fibrillation and venous thromboembolism, anticoagulation for both of those conditions. We'll zoom in on this question of transitions of care, talking a little bit about nursing homes, long-term care, and the hospice setting. We'll then talk a little bit about modifiable bleeding risks, which all of us have a role to play in, and then sort of some concepts from the geriatrics and palliative care worlds, which I'm sure many of us already incorporate, about shared decision-making in this setting. And then we'll briefly touch on some future directions, which hopefully will be the focus of a future webinar. So first, why are we even talking about this as a special subset of the population? What is different about older adults? So the key thing is that this is just going to become increasingly more common. The worldwide population is aging, and the vast majority of anticoagulated patients are age 65 and older. And what many of us have experienced is that what's challenging is that balancing the risks and benefits in this subgroup is really hard, because age increases both thrombosis risk as well as bleeding risk. And then what also happens is that competing mortality, meaning people's life expectancy, which is driven by many things, and we'll come back to that in a minute, really alters these risks and benefits. So first, before we dive into the data a little bit, what do we mean by competing mortality or competing risk of death? So breaking it down, the net clinical benefit of anticoagulation, it depends not only on bleeding and thrombosis risks, but also on an individual's competing risk of death, their life expectancy, because that is the determinant of whether they are going to live long enough to experience these benefits or harms. And life expectancy is certainly influenced by chronologic age, just by how old someone is, but also by frailty, how frail someone is, and other comorbid conditions. So this figure really beautifully illustrates this concept. So in patients with atrial fibrillation, they mathematically modeled the benefit of stroke prevention while accounting for the risk of anticoagulate-related bleeding and the competing risk of death. And as you can see, that horizontal gray line, the net clinical benefit shrinks as age and competing mortality increase, and it really dips below that line. For warfarin, it's at age 87, and for apixaban, it's at age 92. And it's really competing mortality that drives that decline. So the other important concept as we're thinking about FRAIL-AF and its implications moving forward is the concept of frailty. It really brought this idea to the forefront. So frailty is not simply advanced age, which I think all of us are aware of, but it really reflects a state of decreased physiologic reserve and increased vulnerability to stressors. And what this means is that in anticoagulated older adults, it increases the risk of bleeding and the consequences of bleeding, including loss of function, loss of independence. It also increases the risk of competing mortality. People who are frail have a more limited life expectancy, and so it really alters the net clinical benefit of anticoagulants. Okay, so with that background in mind, let's dive into FRAIL-AF, which I think many of us have heard about, but just to review. So FRAIL-AF asked a narrow but clinically common question. So the question is, should we switch frail older adults who are stable on warfarin to a direct oral anticoagulant? And there are a few important points in the design of the trial. So it was an open label, meaning that the investigators could choose which DOAC. Pragmatic trial in the Netherlands, so it was 8 thrombosis clinics in the Netherlands. And they included patients who were age 75 years or older, who were experienced with a warfarin or other vitamin K antagonist. And they enrolled people they used a validated frailty measure called the Groningen Frailty Scale. And they included only people who scored 3 or higher, so some degree of frailty. And about 600 were randomized to stay on warfarin, and about 600 were randomized to switch to a DOAC of choice. About half were switched to rivaroxaban and 20% to apixaban. The other important things about the design of this study is that the patients who are on warfarin, these were all fairly well controlled. The time in therapeutic range for patients in this era in the Netherlands was about 70% on average, so better than most in the US. And it was a superiority trial, so they had a planned interim analysis at 160 events, and they were trying to prove superiority in terms of bleeding risk. So interestingly, the trial was actually halted at that planned interim analysis. And this curve kind of shows you why. Switching from well-controlled warfarin to a DOAC increased bleeding at the interim analysis and led to the trial being halted. So you can see this with the gray bar here, the dark gray, which is DOAC, and the light gray here is warfarin. So when you look at bleeding events, and this was all bleeding events, so they combined both major bleeding, meaning needed a transfusion or hospitalization or critical site, with more minor bleeding, or what's considered minor bleeding. And because of that increased risk, the trial was halted. During that period, they didn't see that switch to DOAC reduced thromboembolism risk, recurrent thromboembolism, or new thromboembolism risk, or death. If you break down the bleeding, so I mentioned that the bleeding risk was higher, at this interim analysis, that was really driven by non-major bleeding. So things like gastrointestinal bleeds that needed medical intervention but weren't necessarily considered major bleeding. So what did we learn from this study? So I think many people took away that in patients who are stable on warfarin with good time and therapeutic range and no issues, it's reasonable to continue a VKA. You shouldn't reflexively necessarily switch to a DOAC. And that is because it's possible that DOACs increase the risk of at least clinically relevant non-major bleeding in this population of frail older adults. There's a few caveats to this study people have brought up. So one is that the majority of patients were switched to rivaroxaban, and we'll talk about that a little bit later. There's lots of observational data that suggests that rivaroxaban may have higher bleeding risk than Eliquis or apixaban. So that could have been one of the drivers. But I think many people took away that stability on VKA is meaningful. But this really is just one piece of the story. And so let's talk a little bit about what we've learned since then. So FRAIL-AF is the catalyst, but let's talk a little bit about atrial fibrillation and what has changed. So I had like 20 people email me a second paper that came out this year that is similar to FRAIL-AF called COMBINE-AF. And what this study did, so FRAIL-AF, as we talked about, was a pragmatic randomized controlled trial. COMBINE-AF they took individual data of patients enrolled in the 4 major DOAC trials in atrial fibrillation, and they tried to replicate the FRAIL-AF population. They basically tried to identify people who, when they were enrolled in the trial, had been on warfarin, they were warfarin experienced or VKA experienced, they were older, and they were frail. They used basically like an electronic method of identifying frail patients. And they looked at many of the same outcomes. So in this subgroup, looking at people who were randomized to switch from stable warfarin to DOAC in these RCTs, and DOACs reduced stroke and systemic embolism. They also reduced intracranial hemorrhage. They also reduced fatal bleeding. If you look at major bleeding overall, so kind of combining those bleeding outcomes, it was similar. But breaking it down, gastrointestinal bleeding was higher in the group switched to a DOAC versus staying on warfarin. And the net clinical outcome when looking at these randomized controlled trial patients was neutral. So if you combine benefit of thrombosis prevention with risk of bleeding, it kind of came out as a wash. So integrating these two studies, which are kind of side by side here in the table, what can we take away? So taken as a whole, stable frail patients who are doing well on warfarin may not benefit from switching to a DOAC because bleeding risk may be higher. But when you look at patients who are enrolled in a clinical trial who seem frail, DOACs do seem to reduce stroke and intracranial or fatal bleeding compared with warfarin, but the GI bleeding risk persists. I think there's a couple caveats to this study as well, to COMBINE-AF, which is, and I think we're going to talk about this a lot more, that people who are enrolled in clinical trials in general are not the same as the people that we see in clinical practice, even though they tried to identify people who are frail. They're often much healthier. And so it remains an open question whether we can directly apply these results. But it sort of comes out that combined AF did look like potentially there could be some benefit to switching to DOAC in certain patients if their bleeding risk is high. But again, kind of supports the idea that this should be an individualized decision because there's a lot of nuance, there's risks and benefits to each decision, and that a individualized discussion is warranted. It shouldn't be reflexive. Okay, so we talked a little bit about combined AF, comparing it to FRAIL-AF, but what about anticoagulant selection more generally? So most of what we've been focusing on so far is sort of the traditional outcomes that we look at in thrombosis. But as we all know, those may not be the most important things to older patients. In many patients identify things other than death that are actually more important to them, like independence or time at home. So this is a cool paper that came out a couple of years ago looking at Medicare patients, so people who are age 65 and older. And they did comparative effectiveness analysis comparing rivaroxaban, warfarin, and apixaban. And really what they found, and the outcomes were not just thrombosis and bleeding, they also looked at a cool outcome called home time. So what this is days alive and out of the hospital or a skilled nursing facility. And it's really a patient-centered outcome that studies have shown that patients really care about. And it captures what matters most to older adults. So looking at comparing these different anticoagulant strategies, apixaban was associated with more days alive and at home compared with rivaroxaban and warfarin, and this was more pronounced in frail patients. Looking at more traditional outcomes, apixaban also had fewer adverse clinical events, both thrombotic events with stroke, major bleeding, or death, compared with other agents. And this was also, the effects were stronger in frail older adults. They also looked at cost, which is of course a huge consideration, particularly as people are on fixed incomes as they age. And when you exclude the cost of the drug itself, which of course is very relevant still, but if you exclude that, apixaban had the lowest medical cost, and that was really driven by fewer hospitalizations and complications. So thinking about atrial fibrillation and what has changed since FRAIL-AF. So the takeaways are, in stable, frail patients doing well on warfarin, think carefully before switching. And that's really still driven by FRAIL-AF, which is the best evidence we have to date on that question. Combined AF kind of made it a little more complex, but also made it easier to have a nuanced discussion that incorporates patients' goals, and that across randomized controlled trial populations, it does seem as though DOACs reduce stroke and fatal and intracranial bleeding, but they increase GI bleeding. So it really is something to take into account when you're thinking about which is the better option for patients. And in frail older adults, there's mounting observational data in atrial fibrillation in favor of initiating apixaban for both traditional outcomes like thrombosis and bleeding, as well as patient-centered outcomes like frailty. And this is particularly true in frail patients. Patient-centered outcomes like home time. And this is particularly true in frail patients. Okay, so we talked about atrial fibrillation. Let's talk a little bit about venous thromboembolism because they really are different. And let's talk a little bit about why. So in VTE, thrombosis versus bleeding risk determines duration. So as you all know, if you look at the guidelines, you're really supposed to balance those two things when you're thinking about whether to stop versus continue anticoagulation in somebody who has either an unprovoked or mildly provoked venous thromboembolism. But what's tricky is that both of those rise sharply with age, and they track pretty closely together, as we've talked about. The other thing is that that sort of crude estimation doesn't take into account things like frailty, things like competing mortality. So it's a different question than an atrial fibrillation because it's a duration question. And the key questions that we have some new evidence on that's really exciting that often come up in these patients are: how intense should the indefinite anticoagulation be? Should we be continuing people on full dose DOAC versus reduced dose? How long, like we talked about? And then there's also emerging data about which drugs may have benefit, particularly in older frail adults. So let's start with how intense. So this is very exciting. This is the RENOVATE trial, which really sought to address this question directly. Can I safely step down intensity after 6 months? So this was also an open label randomized controlled trial, so investigators could choose which DOAC. Of about 2,700 patients with venous thromboembolism who were judged to have high recurrence risk. This was all done at 47 French academic medical centers. And after initial treatment, so after the first 3 to 6 months, they were randomized to continue indefinitely at either reduced dose or full dose, and the investigators could choose either rivaroxaban or apixaban. And their primary outcome, they were hoping to demonstrate non-inferiority in terms of preventing recurrent VTE from the reduced dose. And then their secondary outcome was to show superiority in terms of bleeding. They hoped to show that reduced dose was associated with less bleeding. So their main findings are down here in these forest plots. So their primary outcome, they did not meet their primary outcome. So the reduced dose did not meet non-inferiority margin for recurrent VTE. But I think a very important thing to highlight, and I'm sure this has been covered in previous AC Forum webinars, is that the event rates in both arms, so in full and reduced dose, were very, very low, much lower than was projected, about fourfold lower. And so they did a lot of things to try to increase follow-up time and increase enrollment, but they weren't able to meet that non-inferiority margin, mostly because of very low event rates. But that's important because what that tells you is that the risk of recurrent VTE with both full and half dose is very low. Looking at bleeding, which was a secondary outcome, there was a 39% risk reduction of clinically relevant bleeding. So that's both major and clinically relevant non-major bleeding. And then if you combine those two together, the composite outcome of both thrombosis and bleeding, which is what you're really trying to balance, there was a 33% reduction in the net clinical benefit. So what that tells us then is that the risk of recurrent VTE is with either dose is very low, but they couldn't really prove a non-inferiority, and that's mostly because of issues with the trial itself. But because the bleeding risk is so much lower with half dose, the net clinical benefit clearly supports half dose for almost all patients after 6 months. There's two exceptions though. They did do subgroup analyses, and there were two subgroups that looked like the net clinical benefit favored the full dose. And those are patients who had high risk PE at presentation, and then patients with obesity with BMI greater than 30. For those subgroups, they weren't able to prove that there was a net clinical benefit to dose reduction. Okay, so that's how intense. The RENOVATE trial gave us a lot of important information about how intense. How about how long? So this is a much more complicated question and lots of debate going on. So what is the net clinical benefit of indefinite anticoagulation after a first unprovoked VTE, which is the current guideline recommendation across multiple professional societies? So this is a modeling study, so just bear with me. But modeling can really help when clinical trials can't answer a question. And in this case, this is a decision model or a Markov model that is really trying to be a unified approach that incorporates a bunch of inputs. So it incorporates bleeding risk, it incorporates thrombosis risk. It's also trying to incorporate older adults' complexities. And then using that, it tries to identify a treatment threshold based on life expectancy. And so this is a study that came out in 2023 in Annals, and they looked at all ages, but what we'll focus on is that they also looked specifically at a hypothetical patient at age 75. And they showed that continuing indefinite anticoagulation in that patient showed large reductions in recurrent VTE as expected, but it came at the cost of major bleeding and intracranial hemorrhage. And if you combine those two together, for the average 75-year-old patient, the net clinical benefit of indefinite anticoagulation was not there. There was no net clinical benefit. It was unfavorable. So again, these are modeling studies that are hard to wrap our minds around, but I think the takeaway from this is that the trade-offs in older patients, particularly with frailty or other competing mortality risks, the trade-offs of indefinite anticoagulation may be more uncertain than current guidelines emphasize, and a nuanced discussion is warranted. Okay, so we've talked about how intense, we've talked about sort of the uncertainties about duration. Let's talk about what drug. So this is actually very similar to the data in atrial fibrillation that we talked about. And this was a study that combined Medicare patients with some commercial insurance as well, looking at people who initiated DOAC, so rivaroxaban, apixaban, or warfarin, and compared their outcomes. And so you can kind of see this here in panel A. So this looks at recurrent clot and showed benefit of both DOACs over warfarin, and more so for apixaban than rivaroxaban. Apixaban looked superior to rivaroxaban. And that was even more the case in patients who were over age 65. And it held true across frailty subgroups. Although some of those subgroups were not significant, the trend in most was towards superiority of apixaban and rivaroxaban over warfarin, and in some cases of apixaban over rivaroxaban, but not all. The same findings essentially held true in hospitalization for major bleeding. In older patients and patients with frailty, DOACs were superior to warfarin in initiation for VTE, and apixaban looked superior to rivaroxaban, and that was particularly true in patients with frailty. This data in VTE combined with the data in atrial fibrillation led to a big change in the Beers criteria, which I think some of us are familiar with, but it essentially is a very influential statement that's put out, which examines the appropriateness of medication use in older adults. And the expert panel stated that the change that they made, which was to recommend against long-term treatment with rivaroxaban over alternatives, including apixaban, was based on this observational data. Now, a couple important things. Beers criteria is really not meant to be followed without question. It's meant to be recommendations that a clinician can take into account. They do mention explicitly, and there's a really lovely editorial from AC Forum that emphasizes this point, that avoid is not an absolute contraindication, and we all know that there's many factors that come into play when choosing an anticoagulant, including cost, including once versus twice daily administration, absorption, etc. But I think the takeaway is that there's mounting observational data that suggests that apixaban may be safer, and so in patients who have an option, it may be superior to rivaroxaban. Okay. So summarizing what has changed in venous thromboembolism since FRAIL-AF. So we have good, high-quality trial data now that after 3 to 6 months of full dose direct oral anticoagulant, half dose has greater net clinical benefit that's really driven by reduced bleeding. Think carefully before reducing dose in patients who have BMI over 30, or who presented with high-risk pulmonary embolism. And point number 2 is probably more controversial, but I think it warrants discussion because in a high quality modeling study, the trade-offs of extended anticoagulation are probably more uncertain than current guidelines emphasize, and particularly in older frail patients with competing mortality, shared decision-making based on patients' values may be warranted. And then finally, regarding agent selection, for initiating treatment of venous thromboembolism in older adults, DOACs prevent more recurrent VTE and bleeding than warfarin, including in frail individuals. And apixaban may have lower bleeding risk in frail older adults, but as we talked about, there are always nuances to that decision. Okay, next we'll talk about transitions of care. So again, we are so lucky to have Dr. von Preyss-Friedman here as an expert to discuss this topic, so I'm hoping we can hear a lot more from her about it. But this is an increasingly important public health problem or public health issue to address. About 70% of us will develop needs, and about 50% of us will receive some form of paid care in a facility over our lifetimes. And transition to a new non-independent living setting is really a sentinel event in an older adult's life. And it's a very natural place at which to consider all interventions, and that includes anticoagulation. There's several key features to think about in this transition. And one of them is the time to benefit versus time to harm. And what that really means is that in somebody with limited life expectancy, which is often connoted by this loss of independence, they often go hand in hand, although of course not always. You have to think about, is this patient going to live long enough to benefit from these therapies? And then conversely, are they going to experience harms very soon, such that they will experience harms in the short term, but won't necessarily live long enough to experience the benefits? And that's depicted here in this figure. It's really determined by life expectancy. The other thing that comes up in this setting is when you're thinking about preventative therapies versus symptom management. And that kind of does differ by atrial fibrillation and venous thromboembolism. There is the question often, it's a very common consult question, which I'm sure many of you experienced, of whether somebody might benefit from anticoagulation to prevent symptoms, particularly of venous thromboembolism. Practical considerations are often one of the most important things. For example, INR monitoring in the long-term care setting can be very challenging. Whether the patient has consistent oral intake is another consideration. Goals shift and they're highly individual. There's interesting qualitative data that shows that as patients get closer to death, sometimes avoiding death is the most important thing, and at other times, maintaining independence or dignity supersedes even preventing death. And it really varies by individual and over time. And then the last thing I just want to say is that we don't have a ton of data to guide us. So I think Dr. von Preyss-Friedman is going to mention, like, many of these clinical trials didn't enroll patients in the long-term care setting. So we're really taking data that is from totally different patients and trying to apply it. Okay, but what information we do have. So this was a study that came out fairly recently, just looking at what actually happens when a patient transitions from home to long-term care. So in red at the top of this figure here are patients who are already on oral anticoagulants or OAC. And about 75% of them, that big red bar at the top, continued after they entered long-term care. And about 25%, that's that little wave that's coming down here, stopped. And geriatric conditions and comorbidities, including anemia, a history of falls, cognitive impairment, and frailty, were associated with stopping anticoagulation when somebody transitioned to long-term care. In the bottom, in the blue, are patients who, when they were admitted to long-term care, were not on anticoagulants. And about 80%, this big bar here, stayed off, and about 20% started. And higher CHADS2 VASC score, so higher stroke risk, a previous stroke, and interestingly, frailty were all associated with starting anticoagulation, whereas anemia and more advanced cognitive impairment, as well as being on multiple medications or polypharmacy, were associated with not starting anticoagulation. So I think what this figure sort of shows is that there's lots of variation in practice upon admission to long-term care. There's lots of patient factors that influence these decisions, and there's a lack of clear guidance, which is really driving this variation. Let's touch just briefly on hospice and palliative care, which of course is a subset of patients who are near the end of life. This slide kind of summarizes what we know. So about 30 to 35% of hospice patients, when they just scanned them who were asymptomatic, had a proximal DVT. So it was very common. But interestingly, even among those patients with DVT, it was not associated with any symptoms. It didn't seem to affect survival. And whether the patient had received prophylaxis, so venous thromboembolism prophylaxis with pharmacologic therapy, was not a determinant of whether or not they had a clot. Conversely, about 10% of hospice patients who were followed over time developed bleeding, and that's major bleeding, so very clinically significant in 3 months. And there were several features that seemed to predict risk of bleeding. So patients with cancer, patients with a history of bleeding, and then, of course, people who are taking antithrombotic therapy, including antiplatelet therapy or anticoagulants, that was strongly associated with bleeding risk. So this just challenges the question of indefinite anticoagulation in this setting. It's, again, similar to entrance into long-term care, entrance into hospice, or focus on symptoms should trigger a reconsideration, both of treatment as well as prevention. Just briefly, we talked about how practical considerations really dominate. So I think there's a couple interesting and important considerations for agents. So some patients may prefer injections over oral agents because of nausea or pill burden. And so that's something to think about. We talked about the difficulties in sometimes burdening of INR monitoring, but in other patients it may be appropriate. Eliquis is a twice daily drug. Rivaroxaban must be taken with food. There's, of course, the standard contraindications of liver and kidney dysfunction. And dabigatran, for instance, cannot be crushed in patients who have feeding tubes. So all of these things oftentimes are what influence our decision making in this setting, but need to be taken into account. Okay, so lastly, we're going to talk a little bit about modifiable bleeding risks and then just touch briefly on shared decision making, but hopefully we'll get a lot more input from our other panelists after this piece of the talk. So I think all of us are aware of many things can influence bleeding risk, but they are very prevalent in this population. There's been several AC Forum webinars that have been superb on this question of the combination of anticoagulation therapy and antiplatelet therapy. I won't go into it because it's its own talk in and of itself, but the number of indications for dual therapy is rapidly shrinking, and in most patients, it's a short course at most. And so deprescribing unnecessary antiplatelet medication is a key component of anticoagulation stewardship. Controlling hypertension, always challenging in patients, older, frail patients, but is associated with reduced risk of bleeding. Minimizing nonsteroidal anti-inflammatory agents, considering alternative methods of pain control. And then in appropriate patients, proton pump inhibitors have been shown to prevent gastrointestinal bleeding, which, although can be minor, can also result in significant frailty and functional decline in patients. Lastly, I just want to touch briefly on some concepts from geriatrics that can really be helpful when we're thinking about these complex decisions. One way to improve treatment decision-making in older, complex patients is to use evidence-based tools for communicating about serious illness. So one example of this is called the Patient Priorities Care Framework, which is kind of summarized in this figure here. And this has actually been tested in randomized controlled trial and has been shown to reduce burdensome care. And it involves a few steps, which I think many of us do instinctively, but they just do a nice job of breaking it down step by step. So step one is thinking about goals and values and elaborating care preferences. Step two is considering treatment options within the context of the patient's priorities that you just elicited, and incorporating all the things that we think about when we're seeing a patient who's on long-term blood thinners. But maybe a few newer concepts like their functional status, what they're able to do on their own, as well as how long they may have to live, such that we can think about whether they're going to benefit versus experience harms from a therapy, whether there's potential symptomatic benefit to what we're doing, and then the logistics and burdens. And then, again, there's these natural turning points where this is appropriate, including potentially the transition to long-term care, to think about stopping, which you can think about deprescribing, starting, continuing anticoagulation. And then another key point is that when you make a change or don't, always reassessing as people's goals change, their medical condition changes, and then their life expectancy changes. Okay, so Last thing we'll talk about is what's coming next. So in terms of trials, there is an ongoing direct head-to-head comparison of apixaban versus rivaroxaban. With these observational data, there's always concern that clinicians are choosing one over the other because of things they're thinking about their patients. So for example, if you are worried a patient has higher bleeding risk, you might preferentially give them apixaban versus rivaroxaban, and you can't really account for that in these observational studies. So we'll have a direct head-to-head comparison, hopefully in the next year or so. There are increasingly frailty integrated trials where they're using some measures of frailty or they're enrolling frail patients, and hopefully that will become more and more common. There is a growing recognition, as I mentioned, of the need for more evidence to help us make decisions in patients who are in long-term care settings, both about treatment with anticoagulants as well as preventative therapy. And then the last new kid on the block, which again is probably its own talk, is factor XI inhibitors. So let's talk just a little bit about that. Factor XI inhibitors have had a lot of enthusiasm, and particularly in this patient population, because theoretically it preserves hemostasis while preventing thrombosis. That is, it doesn't cause bleeding but prevents thrombosis. And that is particularly appealing in patients where those two risks are so finely balanced. So this paper literally is just hot off the presses. Arthur actually told me about it. So this is a study in atrial fibrillation patients who were age 75 and older. So the study included all ages, but they did a pre-specified analysis just in that older subgroup. And they compared, I'm going to say it wrong because I've actually never heard it said out loud. They compared a factor XI inhibitor versus rivaroxaban. And basically, in this study, the outcome was bleeding. So it's combined major and clinically relevant non-major bleeding at 2 years, and essentially found that using a factor XI inhibitor was associated with much, much lower risk of bleeding. You can see the hazard ratios there. And when they looked at it continuously, you can see that over time, the bleeding risk really stays stable, whereas over time, the bleeding risk with rivaroxaban actually rose with age. So seems as though it is true, the theory that it caused less bleeding is borne out. However, really, really important to know that this was a phase 2 study, so was not at all looking at efficacy, which is thrombosis prevention. And we have some signals from some other studies that potentially some of these drugs are less effective for thrombosis prevention. So one study in atrial fibrillation specifically was stopped early for lack of efficacy. And similarly, in patients with cancer-associated venous thromboembolism, the trials comparing these factor XI inhibitors to DOACs were also halted because of lack of efficacy. So bleeding does seem to be reduced, but we also need thrombosis prevention. And so the phase 3 study will be the key determinant of whether this is going to be practice changing for our patients. Okay, so we've come to the end. I'll just summarize really quickly some of the things that we talked about. So enduring lessons since FRAIL-AF. So I think FRAIL-AF really, what many people took away is that for stable frail patients who are doing well on warfarin, you don't have to automatically switch. It is okay to continue patients on warfarin because there may be increased bleeding risk with switch, although that's likely driven by non-major bleeding. And that study may be affected by the fact that most patients were taking rivaroxaban. The update is from looking at the randomized controlled trial patients. And again, it made it a little more complex, but in certain ways is freeing because you can have a nuanced discussion and make a nuanced decision in that it does look like even patients who are doing well on warfarin, switching to DOAC reduced thrombosis outcomes and certain serious bleeding events, but like with FRAIL-AF, did seem to increase GI bleeding. So think carefully about switching, but in certain patients where you're very worried about serious bleeding, it may be reasonable to switch. In frail older patients with atrial fibrillation and venous thromboembolism, there is mounting observational data in favor of initiating apixaban, and that is for both traditional and patient-centered outcomes like home time, and across patients who are both frail and non-frail. We just talked about in terms of agent selection, factor 11 inhibition may meaningfully reduce bleeding, especially in older patients, but thrombosis prevention really remains the key unanswered question. We have good RCT data now that after 3 to 6 months of full dose DOAC, half dose has greater net clinical benefit, with a couple exceptions. There is some modeling data to suggest that we can rethink or should be rethinking the risks and benefits of extended anticoagulation, particularly in older patients who may have other competing risks of death. Transition to long-term care is a sentinel event that should trigger reevaluation that incorporates competing mortality as well as updated risks and benefits of continuing blood thinners. And then lastly, and I think this is both a blessing of our field and somewhat of a curse, is that managing anticoagulation is always going to require balancing trade-offs. But there are evidence-based strategies that we can use to match care with patients' priorities. And I'm really excited to talk more with our amazing panelists and hear questions and discussions about how we can best do that.
Wow, thanks, Anna. Just incredible. Cover the topics exactly as they occur in my brain. So that was super, super helpful. We're going to bring our panelists back. We're going to ask that the slides be pulled down so you can see our smiling faces. And I'd really like to throw it over to Sabine. Sabine, you've practiced in this field. You're the president of the PulpMed. The population that we're referencing is near and dear to your heart. I'd love to hear kind of your thoughts and your take on kind of practical applications of what we've just heard. That would be great.
Well, thank you for inviting me as a panelist. It's a pleasure and an honor to work with the Anticoagulation Forum and Dr. Parks. That was an amazing lecture. It said, "I'll give you a gold medal." And thank you for that question. How does it all shake out for those of us who are on the ground, for those of us who are post-acute and long-term care specialists and post-acute and long-term care medical directors who look at systems? And I think I would give an unequivocal yes to the transition into our space, into the long-term care skilled nursing facility space, but actually also into other long-term care spaces, is an ideal point to look at anticoagulation. What you say, well, this is a great time to evaluate competing risk and all of that, and I agree with you, but I want to actually take a step back and say, this is a great time to evaluate the basics. Like, why is somebody on an anticoagulant? What was the triggering event? When was it? And what's the plan? So you switched right to the plan, and the reality of post-acute and long-term care with still very unsatisfactory EHR connectivity in particular is that we often don't know why patients are on an anticoagulant. So that makes this whole discussion even more important. And I know there are a lot of pharmacists on this call, and I want to once again say how important you are to us as collaborators to answer those questions. What I have done in practicality, since I've become a friend of the Anticoagulation Forum, is have a antithrombotic stewardship program in the facilities that I direct. And I also am starting to implement that as a chief medical officer. So what that antithrombotic stewardship program is a team. It definitely involves the pharmacist, physician, or advanced practice provider and the medical director and the director of nursing, but it also involves a social worker, interestingly enough. And so that is where we ask the very basic questions that I just pointed out. What are they on? Why are they on it? What is the plan? Often we don't find that in the discharge summary, and then we all go on a search to answer those basic questions. What we often see is undertreatment in one hand and overtreatment on the other hand. So it goes both directions. So I think the best thing that we can then do is make a recommendation to the attending physician or APP, and then go forth with that to the patient and say, are you okay with that? Or to the loved one, and are you okay with that recommendation? I have really, and I want to point out that the FRAIL-AF study did not include nursing home patients. And I want to say it very clearly as a CMO, the number of citations I have seen and poorly implemented practice that I have seen around INR monitoring is very problematic. In my past stuff, I don't see it as much anymore. So I am not from that perspective, we don't do it well. It is too complicated. I would, if a patient insists on staying on a vitamin K agonist, absolutely, that is their choice. But I am happy that we only have that as an exception. So I've talked long enough, a lot more comments, but let me
No,
up here.
that's great, Sabine. I can tell you, I've been working on a project with Sabine, and I've been very, in my experience, and I don't have a lot of experience in the long-term care facility, but I've seen from my angle, seeing other ones, when we entered this project, I was like, well, do they make these decisions? Or are they just kind of repeaters stations for what happens in the community? And Sabine has been, no, it is their responsibility. They are the provider in that setting. They need to be willing to make a call. And I've been so like, yes, that's exactly right. So Sabine has been great in saying that in that setting, that is your patient and you are the decision maker. And so I just want to, if we have folks on that in that setting, that it is you guys are responsible, and you guys are the best position, I think, especially to be making kind of net clinical benefit decisions. You're having discussions, you're involving the social worker, the goals of care may have shifted. You're in a perfect position. I'd really like to bring Margaret in here. Margaret, this is actually a topic near and dear to Margaret's heart. She's practiced in this area. Her research is focused in this area. And fun fact, Anna trained with Margaret, and I believe probably learned her love for this population probably from Margaret. So Margaret, I'd love to get your kind of high level comments as well, and kind of any kind of practical tips that you can share with us.
Well, one of the frustrating things about being someone who's in anticoagulation, but also why we exist and why it's really exciting, is because there's evidence that guides our decision that is all mediated through the individual, and it's the individual relationship that you have with patients, your understanding of what's important to them, and then your guidance on what is the right path. And so in older patients, I think I love what Sabine said, that there's actually two problems. One is the undertreatment, and then one is the overtreatment. And a lot of that is driven by everyone wants to do the right thing. I believe that everyone tries to do the right thing. And I think one question that came through the pre-registration list was, well, you have someone who's frail, who's older, and falls a lot. And we've just been drilled in our head, if you are on anticoagulants, you fall, something bad is going to happen. You're going to have an intracranial hemorrhage. You should go and get a head CT. So I think people are trying to do that because they're trying to do the right thing. Yet when we look at evidence, it becomes more complicated. And I would love to hear, Sabine, Anna, how do you mediate something like falls with potentially very serious consequences with, again, the benefits of anticoagulants in frail older people?
Sabine, I'll let you go first because you're definitely
Oh,
the
okay.
expert.
All right.
But I'm happy to chime in.
I can tell you how immediate. I mean, the number out there is like 255 falls until it gets fatal, right? I mean, that just seems wrong somehow. Um, but the way you mediate that is like, does the patient need the anticoagulant in the first place? I mean, and you know what? When you look into it, it's like, yeah, well, they're provoked thrombosis from their hip fracture was 5 years ago, and nobody had the guts to stop that anticoagulant, you know. So I think the basic questions apply. You know, is there really a reason for the ongoing? Is there overtreatment potentially? And we see a lot of overtreatment in nursing homes by nature of who our patients are. And so I think that would be the first question. And then you look at all other, and if then is then, and what I'm really excited about, are there, you know, mitigating factors? So, and then now I'm very excited about reducing anticoagulants if they still are at risk. So that's a new tool we have now, and I'm going to pursue that vigorously in my anticoagulation and antithrombotic stewardship. So can we reduce it? Or frequent falls are also a harbinger, often a byproduct of frailty. And so then that is a good trigger to look at what is the what are goals of care right now. Frequent falls, of course, I have to say it, you all know, is also a byproduct of polypharmacy. So we don't want to forget about that as well. So you look at the faults themselves and you look at the indication for the anticoagulant both.
Yeah, I totally agree. I think that study where it's like 255, I think there's been some newer studies that have sort of called that into question. Um, and the other thing I would say is that, you know, I think in some other fields, this sort of ethos has pervaded a little bit more, but there are like interventions to prevent falls too. And I think we're not always thinking about that in an anticoagulation clinic. And that there may be benefit to patients for continuing anticoagulation, but also there's huge benefits to like intervening to prevent falls. So things like home PT evaluation, you know, various strengthening exercises, reducing sedating medications. You know, that's not typically within our wheelhouse, but it can be because oftentimes we have more time than some other providers the patient may be seeing, or at least more time to focus on this question. So I would say, like, just like Sabine, I don't reflexively stop if a person is falling. I do see it as more of a marker that it may be time to like at least sit down and think about both the indications as well as the contraindications, and then see if we can reduce the fall risk. There's no cutoff though. This is where the evidence is, you know, the evidence goes both ways. And so it really involves kind of like a shared decision-making process.
Yeah, you know, the way that I think about that, just like the HAS-BLOOD score isn't really designed to determine should you or shouldn't you anticoagulate, it's designed to find modifiable risk factors. Our first thought when somebody is falling shouldn't be, I need to stop the anticoagulant. It's, can I mitigate the fall risk? And we often don't go there. It's at a higher level of care needed. Is there some kind of a, you know, implement that needs to be put into place to prevent falls? So absolutely, I completely agree. You know, one of the things that I would ask this group about as well is, and we have just a minute, very quick answers, but the what I find a little disturbing is when decisions are made for patients. So they go on hospice and it's like, we're stopping your anticoagulant. Or we go on, or, you know, oh, this person looks frail, so we're going to throw them straight and they need to have a Watchman device instead of, you know, considering anticoagulation device. Can you know, maybe Ann, I'll come back to you. Can you speak to that, like the appropriateness of decisions being made based on clinician bias?
Yeah. I think there's some good evidence that even specific to anticoagulation decisions, that we can all benefit from being better communicators. It's very challenging, but it's also like one of the beauties of our jobs. Some things that are notable are that we often don't talk about cost explicitly, which is like so important to so many of our patients. We also oftentimes overemphasize risks and underemphasize benefits. I'm sorry, the reverse. Overemphasize benefits and underemphasize risks when we're talking about these questions. And this is true like across all fields. It's just part of how humans are wired. But I think as you're saying, as you're alluding to, there are like trainings for how to do these conversations better, particularly when people are seriously ill. And I think it just isn't necessarily like a part of every sort of silo in medicine, but there's a figure in our talk that kind of just shows that like oftentimes anticoagulation is like a very small part of these patients' lives. They have a lot of other things going on and isn't necessarily the main driver of either their risk of death or like their quality of life. So taking a step back and putting it into context of what the patient actually cares about and what their goals are, even though it takes time and effort, is really important. I don't know if that answered your question explicitly. I think we all can get better at it. I myself have a very hard time stopping blood thinner. I'll be like totally frank because there's no like I've never seen a guideline for how to do that. We have tons of guidelines for starting, but very few for stopping. And there's a clinical inertia is really strong and it takes time. So, just like Sabine said, there are these natural, and Margaret, there are these natural turning points that can kind of, everybody can take a step back and say like, oh, my life has changed. And how can we think about things moving forward?
Absolutely. Yeah. So thank you. Yeah, so much for that. And unfortunately, we have come to the end of our time, but this has been an amazing chat. Thank you so much to our amazing experts, Anna, Sabine, and Margaret. Appreciate the opportunity to chat here about these topics. We look forward to seeing you all on the next webinar. Thank you all.
Thank you so much.